This is Dr.K.V.Swathi, Senior Lecturer, Department of Body Medicine and Radiology, SRM Dental College, Ramapuram, presenting the dental key content for September 2023. The topic will be on temporomandibular disorders. The outline of this key content will include what are basically about clinics, the anatomy of temporomandibular joint, anatomy of clinical interest, the etiology of temporomandibular joint disorders, the classification of temporomandibular joint disorders, comparison of RBC-TMD versus TMD criteria, the assessment of temporomandibular joint disorders, which is basically about the history taking and core components of clinical examination, what is behavioral assessment, when do we need to and evaluate the psychosocial element, certain provocation tests, the temporomandibular disorders and features, diagnosis and management of certain common disorders. So what are temporomandibular joint disorders? Temporomandibular disorders is a collective umbrella term that embraces a number of clinical problems that involve the masticating muscles, the temporomandibular joints, associated structures, or bone. The main characteristic features of these joint disorders will include facial pain, rigidity of the joint, or the muscles of mastication, limitation or deviation of mandibular movements, protrusion, retrusion, and lateral movements, hyperalgesia of the musculoskeletal structures, which basically denotes the increase of the heightened sensitivity of pain to even normal threshold, temporomandibular joint sounds such as clicking, popping, grating during jaw movement and function. So there was a person by name Boston who gave a theory or the etiology of TMD. He basically linked occlusal disharmony as the main attributing feature of temporomandibular joint disorder. So once the occlusion is corrected, the joint problems will resolve according to this theory. So this is a schematic representation to show you the anatomy of temporomandibular joint, which basically includes the condyle, and we have the articular disc, which is a fibrocartilage disc that is an S shape that is seen between the condyle, head of the condyle, and the articular ends. So that is the region of glenoid fossa, and we have the superior synovial cavity and the inferior synovial cavity. So this denotes the articular disc. Here we have the superior head of the lateral pterygoid and the inferior head of the lateral pterygoid, the muscle of mastication. Some of the temporomandibular joint ligaments include sphenomandibular ligament and the stylomandibular ligament, and we have various accessory ligaments. So this is also the lateral ligament, and the joint which involves the articular disc is actually covered by a fibrocapsule. So what are the muscles of mastication? We have four muscles of mastication: the fan-shaped muscle, which is the temporalis, masseter, lateral pterygoid, and the median pterygoid. So this is again to show you the blood supply and nerve supply of the temporomandibular joint. So what is the anatomy of clinical interest? The first anatomy of clinical interest would be the jaw jerk reflex. When you slightly tap or give a downward tap to the chin, so there is opening of the mandible. So this is the polysynaptic reflex. So this jaw opening reflex is the next reflex. It's basically due to the action in the trigeminal ganglion. So what are the etiological factors of temporomandibular joint disorder? The first one would be a malocclusion or a change in occlusion, stability of the maxillomandibular relationship, temporomandibular joint hypermobility, trauma which includes during dental procedures, oral intubations for general anesthesia, yawning, hyperextension associated with cervical trauma, certain parafunctional habits like bruxism, which is your night grinding, tooth clenching, jaw guarding, lip or cheek biting, sleep disturbances, comorbidity as in the form of the other rheumatic, musculoskeletal, or pain disorders where the patient has a concurrent systemic disorder in the body, emotional distress or emotional pain, poor general health, and on overall unhealthy or a sedentary lifestyle. Taxonomy and classification of temporomandibular joint disorders include temporomandibular joint disorders, masticating muscle disorders, headaches, and associated structures. It includes the cervical spine related region. So what's the classification of temporomandibular joint according to the DCTMD criteria, which can be referred to the article by Shipman et al. In 2014. So this was the diagnostic criteria for temporomandibular joint disorder, which is being widely used. Classified into myalgia, myofascial pain with rental, arthralgia, headache, attributed to TMD, disc displacements with reduction with intermittent locking, without reduction with limited opening, without reduction without limited opening, degenerative joint disorders, which include osteodegenerative changes and subluxation disorders. So what's the difference between the DCTMD and the RBC-TMD criteria? So the RDCTMD was the earlier criteria that was given in the early 1992, whereas the DCTMD included a research protocol which was later updated in 2014. So as we can see, all the presence of a masticatory system pain, like headaches, have been included pain or headache modification with jaw movement function or parafunction. The examination remains the same, whereas arthralgia has been included in the diagnosis. Myalgia, myofascial pain with referral has also been included in the latest DCTMD criteria. And pain with palpation or opening, local myalgia, which is a new diagnosis or a new diagnostic term, myofascial pain. Myofascial pain with referral, which is basically a unilateral pain that has been referred to the shoulders. And then sustained palpation with identification of referral patterns. Spreading pain can also be present, has also been included. Headaches is an exclusive classification given by the International Headache Society. It's also been covered under the DCTMD criteria. So how do we assess temporomandibular joint disorder? The first, of course, would be during history taking. So in the history taking, some of the important features or important probing questions that we must ask the patient would include the location of pain, frequency of episodes, where is the pain as it worst, aggravating and relieving factors, thermal sensitivity of the pain, joint noises, jaw motion, whether there is any hindrance during protrusion, retrusion, or lateral history of any previous trauma, occlusal wrist harm, and previous treatment history, which includes both conservative, pharmacological, and surgical management. So this is how a schematic representation shows how do we go with the clinical assessment of temporomandibular joint disorder. So we have to do what is known as the inter-incisor mouth opening. The normal mouth opening of a healthy patient or healthy subject would be more than 35 mm, whereas in TMJ disorder, the mouth opening is limited. And then we have to palpate, the patient locates the pain. We have to palpate the lateral pole. A bimanual palpation is done. We have to check an Oscar tail for joint sounds. And we can also tap it on to an electromyography to assess whether the muscles have been affected. So when do we need the psychosocial evaluation first in the temporomandibular joint disorder? Nowadays, we have another exclusive treatment for cognitive behavioral therapy because emotional distress has been linked as a probable etiology of the TMJ disorder. So some of the provocation tests for temporomandibular joint disorder includes a static muscle contraction test, dynamic muscle contraction test, bilateral loading via clutch, and lateral loading via clutch. So some of the common temporomandibular joint disorders and its features. So this is again to show how the mouth open or the mouth has a momentary deflection on opening and closing. So the opening pathway deviates from a straight opening, but the midline relationship returns back to the sometimes you have different parts of closure as well. So this is to show how we have both the open and closed mouth position. About the anterior disc displacement, because disc displacement or internal derangement of TMJ is the most common temporomandibular joint disorder. So this is a case of an anterior disc displacement of TMJ. The disc has slipped anteriorly from the condyle on opening, and as we can see on closing, there is reduction of the disc back to the position between the head of the condyle and the articular head. Whereas in disc displacement without reduction, even while closing, the disc has slipped anteriorly. So MRI shows a hyperintense signal of the disc in case of certain infections. So this is a case of heart tissue imaging, probably a CT, shows some degenerative changes of the condyle as well as the articular. An electromyogram showing various muscle or trigger points. The masticatory muscles are affected, especially in cases of myofascial pain, which is again a very common temporomandibular joint disorder. So what are the diagnostic tests for temporomandibular joint disorders? Basics include plain film radiography, plain film tomography. Initially could be an orthophantom plan supplemented with a TMJ tomography, both in open and closed mouth position. We have various temporomandibular joint views, such as the transperineal, transpharyngeal, and transporvital. Then arthrography, CT, MRI. MRI is an excellent soft tissue image, especially when we are going to have pathologies involving the articular disc. Single photon emission for computer tomography when we are suspecting tumors, and radioisotope fusion imaging or nucleotide scanning. MRI images to show the different shapes of the articular disc. Normally it's in the hourglass shape. Then we have a kidney or a bean shape. This is a flaccid variety. This is an eyeglass type, and this is most amorphous type of articular disc. So how we have the relationship between the condyle and the articular disc. So here, so this black Soft tissue, which is a fibrocartilage, shows the disc and how it is slipping anteriorly on opening, and on closed mouth position, it has returned back to its normal position between head of the condyle and the articular end. Again, to show the joint space, so the joint space as it gets reduced, so A shows a healthy joint space, there's sufficient joint space between the articular disc and the articular element. When the joint space is reduced, two bony surfaces come in contact, which causes friction and osteodegenerative changes. Some of the changes in the condyle and the fossa, condyle can also have certain kind of flattening and erosive changes because of osteodegenerative arthritis. So this is again a case of perforations of the disc. So according to the National Institute of Health Conference on PMT, they have given various consensus that significant problems exist with the present classification. So because the diagnosis is simple, because these classifications are based on the signs of symptoms rather than the etiopathogenesis, there is no consensus whether PMJ problem should be treated, which has to be treated first, how and when it should be treated, whether we want to go to the pharmacological or conservative or the surgery. The preponderance of data does not support the superiority of any method for the initial management. Majority of the PMJ disorder patients should actually be treated with a conservative management or non-surgical or pharmacological management. It should be a reversible therapy. Efficacy of most treatment approaches is unknown as they have not been adequately evaluated in long-term studies. We need long-term cohort or randomized control trials to give a more conclusive decision on which diagnostic and treatment strategy we should pursue. Therapies permanently altering the occlusion of the patient should not be recommended. Surgical intervention should be considered only as the last resort if patients persist with significant pain and dysfunction, showing evidence of pathology or internal rehabilitation. Relaxation and cognitive behavioral therapies, and there are certain therapies like oral myofunction therapy that has been treated for managing chronic temporomandibular joint pain. Some of the drugs that have been used mainly being go for muscle relaxants. Apart from that, NSAIDs, opioids, corticosteroids, and antidepressants have also been tried when it's particularly linked to emotional distress or trauma. Again, just a schematic representation to go how we systematically go with the patient history and physical examination. And then we check for any recent trauma or dislocation. And then we go for imaging. We also do provocation tests. So the initial line of management is conservative therapy, like patient behavior education, self-care, how to do exercises. And then we go for pharmacological management. And finally, we go for surgical management as the last.